Usually when we think about a human body pushed to its absolute physical limits, there's this expectation of a really visible, dramatic event.
Right, like something you can easily see.
Yeah, exactly. Like an ultramarathon runner crossing a finish line or, a mountain climber just gasping for oxygen at the summit. You can see the strain, the sweat, the sheer mechanical effort of it all.
Because it's entirely external. The environment is the challenge, and you are watching the body visibly react to that stress.
But then you step into the world of obstetrics, and suddenly the most extreme physical marathon a human body can endure is happening completely out of sight.
Completely hidden.
Yeah, we're looking at a physiological landscape that is radically transforming day by day, while the person might just be, I don't know, sitting across from me on the bus. I was diving into the case studies from the second edition of Self-Assessment in Obstetrics and Gynaecology by 10 Teachers earlier, and it really reframed this whole concept for me.
It's a fantastic text for exactly that reason.
It really is. And for you listening, whether you're a medical student, a young professional, or just a curious self-taught learner, our mission today is to give you a really comprehensive, scientifically rigorous summary of these core concepts. We're going to navigate the physiological changes of pregnancy, critical obstetric emergencies, and complex gynecological pathologies.
And we are not going to hold back on the details.
Absolutely not. So, okay, let's unpack this. Because this transformation, it's almost disguised as an everyday occurrence.
What's fascinating here is the sheer scale of that hidden adaptation. To understand the pathologies, to really know what it looks like when something goes wrong for a patient, you have to first comprehend this radical new normal.
Which is a lot to take in.
It is. It is not merely a localized event happening down in the pelvis. It is a complete head-to-toe systemic overhaul.
Right. So if we look at the cardiovascular system, the textbook notes that a maternal heart rate increases by 10 to 20%.
Roughly, yes.
And the actual volume of blood pumped with every single beat. The stroke volume increases as well. So overall, cardiac output is jumping by 30 to 50%, which is wild. Why is the body suddenly demanding that much more output?
Well, it really comes down to constructing and maintaining an entirely new high-flow vascular bed, the placenta. The uterus goes from an organ that requires a tiny fraction of blood flow to one demanding hundreds of milliliters every minute to sustain the fetus.
Just a massive increase.
Exactly. And to accommodate that, the maternal body physically needs more fluid. Plasma volume, the liquid part of the blood, increases by roughly 50% over the course of the pregnancy.
But wait, if they're producing all this extra fluid, what happens to the actual red blood cells? I mean, if I look at the lab results in these case studies, the patients frequently look like they're anemic.
Yes, they do.
So why do their blood tests say they have low hematocrit if the body is supposedly, ramping up production?
That is a brilliant quirk of physiology, actually. The body is indeed producing more red blood cells, but that production simply cannot keep pace with the massive 50% expansion in plasma fluid.
Oh, I see. So it's a dilutional effect? You have more red blood cells overall, but they're just swimming in a much larger pool of liquid?
You've got it.
Oh.
That's the mechanism behind what we call physiological anemia of pregnancy. The cells are there, they are just diluted.
To me, this is like a factory suddenly needing 50% more coolant to run the machines, but they have to pump all that extra fluid through the exact same pipes.
That's a great way to visualize it.
Which leads me to a really critical question, though. If plasma volume increases by half, and you are pushing all of that extra liquid through the same vascular system, why doesn't the patient's blood pressure just absolutely skyrocket it?
Well, in a rigid system, a sudden 50% increase in fluid would cause pressure to burst the pipes. But the pregnant body anticipates this. Early pregnancy brings about a profound decrease in peripheral vascular resistance.
Meaning the vessels change.
Yes, the blood vessels literally relax.
Yeah.
The smooth muscle in the vessel walls dilates, creating more space for that massive fluid volume. Because of this vasodilation, maternal blood pressure actually falls in the second trimester.
Wait, it falls?
It does. It drops before slowly creeping back up to normal non-pregnant levels by the time they reach term.
That is incredible. And driving a lot of these early changes, if I'm reading the text correctly, is a hormone called human chorionic gonadotrophin, or HCG.
Yes. HCG is the hormone detected by a standard pregnancy test.
Right, the one everyone knows.
Exactly. Its primary job in those early weeks is to act as a distress signal to a temporary cyst on the ovary called the corpus luteum.
And what does it tell the cyst to do?
It essentially tells the corpus luteum, don't break down, keep producing progesterone. And it is that surge of progesterone that helps relax the smooth muscle in those blood vessels, allowing the blood pressure to drop.
It's an incredibly delicate balance. But because the maternal body is operating at such extreme physiological limits, just, staying on that tightrope requires constant vigilance.
That vigilance is the entire foundation of antenatal care. We are essentially tracking this invisible marathon, looking for the earliest signs that the body is failing to adapt.
And that starts pretty early on, right?
Very early. We start with a dating scan at around 12 weeks. It confirms viability and establishes the due date, but crucially, it checks for multiples.
Because twins change everything.
They do. If there are twins, we have to determine chorionicity, meaning do they share a single placenta or do they each have their own?
Why does sharing a placenta change the game so much?
Well, if we connect this to the bigger picture, a shared blood supply means shared risks. Monochorionic twins can develop twin-to-twin transfusion syndrome, where blood flows unevenly from one twin to the other.
Oh, wow. That sounds dangerous.
It requires intense specialized surveillance. Then, as the pregnancy progresses to between 18 and 22 weeks, we perform the anomaly scan, looking comprehensively at the fetal anatomy.
Okay. But while we are looking at the fetus, the clinician is also constantly measuring the mother's adaptation, right? Because when that cardiovascular system we just talked about starts to fail, it triggers one of the most dangerous conditions in obstetrics, which is preeclampsia.
Yes, exactly.
I'm looking at the diagnostic criteria here. It says a blood pressure greater than 140/90, combined with significant protein leaking into the urine, usually greater than 0.3 grams over 24 hours. But how does high blood pressure cause protein to leak into the urine?
This is where understanding the underlying mechanism is vital. Preeclampsia is not merely high blood pressure. It is a multi-system crisis rooted in the placenta.
Okay, how so?
If the placenta doesn't implant perfectly into the uterine wall early on, it doesn't get enough oxygen. In distress, it releases inflammatory factors into the mother's bloodstream.
Like sending out toxic distress flares.
A very apt way to describe it, actually. Those distress flares damage the mother's endothelium, the delicate inner lining of all her blood vessels. Think of the endothelium like the non-stick coating on a frying pan. When it is damaged, things get sticky and leaky. In the kidneys, this leaky, damaged lining allows protein, which is normally kept securely in the blood, to spill out into the urine.
So the high blood pressure and the protein are really just symptoms of a much deeper systemic vascular breakdown.
Precisely. And if the damage continues unchecked, the patient can develop HELLP syndrome.
Remind me what HELP stands for again?
Hemolysis, elevated liver enzymes, and low platelets. It involves the physical shredding of red blood cells, severe liver damage, and a dangerous drop in platelets.
That sounds terrifying.
It is. Or it can progress to eclampsia, where the brain swelling becomes so severe it triggers massive full-body convulsions known as tonic-clonic seizures, and we treat that with magnesium sulfate to prevent the seizures.
Here's where it gets really interesting for me as a learner. I know swollen ankles, or edema, are a notoriously common complaint for pretty much anyone in their third trimester.
Very common, yes.
So how do you, as a clinician standing in the room, distinguish between someone who just has normal swelling from carrying a baby and a patient who is stepping over the edge into this catastrophic endothelial breakdown?
That is the quintessential clinical challenge. You have to look past the ankles and search for systemic red flags. Because the blood vessels in the brain are leaking fluid, you check their neurological status.
What are you looking for specifically?
You test their reflexes. If they are hyperactive or if tapping the ankle causes the foot to involuntarily spasm, a sign called clonus, the central nervous system is dangerously irritable.
And what about checking their eyes? I read something about papilledema.
Yes. The optic nerve is basically a direct physical window to the brain. Papilledema is swelling of the optic disc at the back of the eye, indicating that pressure inside the skull is rising.
Wow.
You also palpate the right upper quadrant of their abdomen. If there is severe pain there, it means the liver capsule is literally swelling and stretching from the disease.
It really paints a picture of treating the entire human, not just staring at a blood pressure cuff. And all of this careful monitoring ultimately builds toward the physical climax of the process, which is labor.
The main event.
Right. And while childbirth is designed to be a natural physiological event, the delivery suite demands clinicians be primed for sudden, life-threatening emergencies. So, what happens when the perfect mechanics fail?
Well, the most dramatic mechanical failure is shoulder dystocia. The fetal head delivers normally, but then progress just stops. The anterior shoulder of the baby becomes physically wedged behind the mother's pubic bone, the pubic symphysis.
So the head is out, but the body's completely trapped, and presumably the umbilical cord is getting compressed in the birth canal.
Exactly. The oxygen supply is severely compromised, so the clock is ticking in a matter of minutes.
The textbook outlines the first-line physical maneuver for this, the McRoberts maneuver. You essentially grab the mother's legs, hyperflex her hips, and push her knees right back toward her abdomen.
Yes, that resolves about 90% of cases.
But how does just moving the mother's legs free a trapped shoulder?
It alters the geometry of the pelvis. By maximally flexing those hips, you physically rotate the pubic bone upwards and flatten out the lower spine.
So it makes the opening bigger.
It doesn't necessarily make the opening wider, but it straightens the angle of the pelvic canal, and that is often just enough to allow that trapped shoulder to slip free.
That structural fix resolves the vast majority of cases. But what about when the mechanics work perfectly? The baby is delivered, but the uterus fails to adapt afterward.
Then we face a hemorrhage.
Right, postpartum hemorrhage, or PPH, which is defined as losing more than a liter of blood in the first 24 hours. I understand clinicians use the 4 T's to find the source of the bleeding tone: trauma, tissue, and thrombin.
Exactly. It acts as a rapid cognitive framework. Tone refers to uterine atony, where the muscle fails to contract. Trauma covers physical lacerations.
And tissue.
Tissue implies retained placental fragments holding the blood vessels open, and thrombin points to an underlying failure of the blood to clot.
Okay, I have to challenge this framework, though. It's like a pilot's rapid pre-flight troubleshooting checklist when an engine stalls. In the pure chaos of a massive hemorrhage with blood pooling and alarms going off, you can't just stand there reading down a checklist like you're rebooting a computer.
That's very true.
So what do you actually do the second you realize she is bleeding out? Do you prioritize them?
This raises an important point about clinical reality versus textbook theory. You don't weigh all 4 equally at first. You play the odds. Uterine atony, a failure of tone, is overwhelmingly the most common cause.
Oh, right.
The thick muscle of the uterus, the myometrium, is supposed to act like a living tourniquet. When the placenta detaches, those muscle fibers must violently clamp down to crush the bleeding blood vessels. If the uterus is relaxed and feels like a soft bag of dough, those vessels remain wide open.
So your first physical instinct has to be treating tone.
Immediately. You place your hands on the mother's abdomen and physically massage the uterus to stimulate that muscle to contract. Simultaneously, you administer drugs like intravenous syntocinon to chemically force the muscle to clamp down.
And then you check the others.
Right. Only once you are aggressively managing tone do you have the mental bandwidth to inspect for trauma or retained tissue.
It is intensely tactile. Now consider how perfectly that uterine muscle and the surrounding hormones have to perform to sustain and deliver a pregnancy. What happens when that exact same intricate machinery misfires when a patient isn't pregnant?
That shifts us into the realm of gynecology.
Exactly. And a prime example of an endocrine misfire here is polycystic ovary syndrome.
PCOS is an incredibly common, complex endocrine disorder. It is characterized by anovulation, meaning the ovaries fail to release an egg regularly, leading to erratic or absent periods.
And it often presents with physical symptoms too, right? Like hirsutism, which is excess facial or body hair. How does an issue with the ovaries cause excess hair growth?
It comes down to testosterone. Patients with PCOS often have an underlying issue with insulin resistance, accompanied by a raised BMI. This metabolic disruption causes the ovaries to produce excessive amounts of androgens, like testosterone.
So just high testosterone levels.
That, and furthermore, the liver produces less of a crucial protein called sex hormone-binding globulin, or SHBG.
Okay, what does SHBG do?
Imagine SHBG as a fleet of transport vehicles. Usually, they bind up the testosterone in the blood, keeping it inactive. Because patients with PCOS have fewer of these transport vehicles, there is significantly more free, biologically active testosterone circulating in the bloodstream.
And that free testosterone is what causes the symptoms.
Exactly. It directly stimulates the hair follicles and sebaceous glands, causing hirsutism and acne.
So it's not just a reproductive issue, it's a full metabolic syndrome. And just as the endocrine system can produce these complex cascades, the physical structures of the ovaries can produce some truly bizarre mechanical pathologies. I'm looking at the section on ovarian cysts.
Ultrasound morphology is our primary guide here. A simple, fluid-filled cyst is usually entirely benign. But sometimes the ultrasound reveals complex structures, solid areas, calcifications, and mixed densities.
Which brings up one of the most mind-blowing pathologies I've ever read about: the dermoid cyst or mature teratoma.
They are definitely unique.
When I first learned about dermoid cysts, I pictured them as an anatomical lost and found box.
Yeah.
Because they originate from germ cells, the cells designed to build an entire human, they can grow completely random tissue types. You can have a cyst on an ovary that contains fully formed teeth, hair, bone, and sweat glands.
It sounds like science fiction, but it is a well-documented reality in gynecological surgery. You can spot them on an MRI because of those fatty deposits and calcified elements.
It's just wild.
It is. But while dermoids are benign, the constant challenge for a clinician is distinguishing a safe, benign cyst from a malignant ovarian cancer. To aid in this, we frequently test the blood for a tumor marker called CA-125.
Okay, so what does this all mean for preventative medicine? If CA-125 is a marker that elevates when someone has ovarian cancer, why isn't this part of a routine annual blood panel for everyone? It seems like an incredibly easy way to catch cancer early.
It seems logical, but it ignores the biological reality of what CA-125 actually is. CA-125 is a nonspecific protein produced by the coalomic epithelium.
Which is what, exactly?
Think of it as a biological wallpaper that lines the entire inside of the abdomen and covers the reproductive organs. Yes, epithelial ovarian cancer cells mutate and produce massive amounts of this protein. However, any irritation or inflammation of that wallpaper will also cause it to shed CA-125 into the blood.
Oh, I see. So if a patient has endometriosis, where tissue similar to the uterine lining grows outside the uterus and causes severe pelvic inflammation,
their CA-125 levels will spike. A severe pelvic infection like PID will cause it to spike. Yeah. Even a normal menstrual cycle can elevate it.
That's a lot of false alarms.
Exactly. If you screen the general population, you would generate a tsunami of false positives. You would be subjecting young, healthy women to severe anxiety and potentially invasive, risky surgeries simply because a benign inflammatory process triggered the marker.
Wow.
CA-125 must only be interpreted in the context of an abnormal ultrasound morphology, like using the risk of malignancy index.
It's all about the clinical context. You can't just rely on a single data point. And that need for rigorous, high-stakes interpretation is exactly what's required in acute gynecological emergencies. One of the most terrifying scenarios in these case studies is early pregnancy bleeding and pain, pointing to an ectopic pregnancy.
An ectopic pregnancy happens when the fertilized embryo implants anywhere outside the protective cavity of the uterus, most frequently getting stuck in the narrow fallopian tube.
And as it grows, it stretches that delicate tube to the breaking point. The classic presentation is pain on one side and vaginal bleeding. But the symptom that truly stands out to me is shoulder tip pain.
It's a very specific symptom.
Right. Why on earth would a rupturing pregnancy in the pelvis cause sharp pain at the tip of the patient's shoulder?
It is a fascinating trick of the nervous system. When an ectopic pregnancy ruptures, it bleeds heavily into the abdominal cavity. That pooling blood is highly irritating, and it travels up to irritate the diaphragm, the muscle you use to breathe.
Okay, but how does the diaphragm connect to the shoulder?
The diaphragm is innervated by the phrenic nerve, which originates all the way up in the neck, sharing the exact same neural pathways as the nerves that supply the shoulder.
Oh, so the signals get crossed.
Exactly. When the diaphragm screams in pain from the bleeding, the brain gets confused about where the signal is coming from, and it projects that pain onto the shoulder. It is a massive clinical red flag for internal hemorrhaging.
When a patient is rushed to surgery for a ruptured ectopic, the textbook notes the surgeon has a critical choice to make regarding that damaged fallopian tube.
Yes, the management can be expectant, medical with methotrexate, or surgical.
And in surgery, they can perform a salpingectomy, completely removing the tube, or a salpingostomy, where they slice the tube open, remove the pregnancy, and attempt to leave the damaged tube in place. Why would a surgeon ever choose to leave a scarred, damaged tube behind instead of just removing it to be safe?
This highlights the profound, sometimes heartbreaking weight of gynecological surgery. You are balancing saving the patient's life in the present moment with preserving their ability to create life in the future.
Right.
If a patient has a perfectly healthy tube on the other side, the standard guideline is to remove the damaged tube. A scarred tube is to trap. Leaving it drastically increases the chance that a future embryo will get stuck there again.
But what if they don't have another healthy tube?
That changes the entire calculation. If the patient has already lost their other tube to a previous ectopic pregnancy or infection, removing this damaged tube renders them permanently, naturally infertile.
That's a huge decision.
It is. In that specific scenario, the surgeon will attempt the salpingostomy. They leave the damaged tube because preserving even a tiny fraction of a chance for natural conception is considered vital for that patient's future.
It's a decision with lifelong consequences made under the incredibly high pressure of a bleeding emergency. Another area where precise decision-making alters a patient's entire future is in cervical disease.
Absolutely.
The smear test is the cornerstone here. But I want to be clear about what a smear actually is. It's looking for dyskaryosis, right?
Yes. Dyskaryosis means abnormal cellular changes. A clinician gently scrapes cells from the surface of the cervix and sends them to a lab to be examined under a microscope, looking for early signs of viral damage.
But the smear test is just a screening tool. I always think of it like looking at a blurry satellite photo of a forest. You can see some weird discoloration from space, so you know something is wrong, but you don't know if it's a fire or just a weird shadow. If the smear is abnormal, the patient gets sent for a colposcopy.
And following your metaphor, the colposcopy is getting boots on the ground. The clinician uses a specialized microscope to directly inspect the physical terrain of the cervix.
See exactly what's going on.
Right. They apply chemical stains that make the abnormal, rapidly dividing cells turn stark white, allowing them to take a precise, targeted physical biopsy of the damaged tissue.
It's that physical tissue sample that gives the actual diagnosis of cervical intraepithelial neoplasia, or CIN. And if the lab confirms severe precancerous changes, known as CIN3, the clinician removes the abnormal zone, usually with a heated wire loop in a procedure called LLETZ.
Which stands for large loop excision of the transformation zone.
Right. They literally cut the pathway to cancer short before it can ever cross the starting line.
It is one of the most successful examples of proactive, preventative medicine we have in modern history.
We have covered an immense amount of physiological ground today. We've traced the massive cardiovascular overhaul of a normal pregnancy, unpacked the placental breakdown of preeclampsia, and examined the pure mechanics of shoulder dystocia.
And we looked at how metabolic issues drive PCOS, why inflammatory markers deceive us, and the high-stakes surgical decisions surrounding ectopic pregnancies.
What ties all of these diverse concepts together is the requirement for a clinician to synthesize multiple physiological systems simultaneously. You are never just looking at one organ.
Exactly.
Now, before we wrap up, I want you, the listener, to picture this. You are holding the pager. You are sprinting down the hall to the delivery suite. A patient who delivered a healthy baby an hour ago is now experiencing a massive postpartum hemorrhage. Quickly, mentally recite the 4 T's you need to evaluate right now to find the source of the bleeding.
Take a second to think.
Did you pull them up? Tone, trauma, tissue, and thrombin. Did the uterus fail to contract? Are there lacerations? Is part of the placenta retained? Or is the blood failing to clot?
If you can retrieve that framework under pressure, you are on the right track.
Absolutely.
And I want to leave you with a final reflection to mull over as you go about your day. We live in an era of unbelievable medical technology. We have advanced surgical robotics, rapid genetic sequencing, and high-resolution MRI machines that can visualize the chambers of a fetal heart in real time.
It's amazing what we can do now.
It truly is. Yet, despite all of this profound innovation, the foundational practices of obstetrics and gynecology still rely heavily on ancient, tactile clinical skills.
It's incredible when you really think about it.
Consider the mechanics we discussed today. Diagnosing the most dangerous cause of a hemorrhage requires physically feeling the firmness of the uterine muscle through the abdomen. Resolving a life-threatening shoulder dystocia requires physically grasping a mother's hips and altering the geometry of her pelvis.
Or assessing a cervix, which requires looking directly through a speculum with your own eyes.
Exactly. Technology is a brilliant and necessary assistant. But in this specialty, the human touch remains the ultimate, irreplaceable diagnostic tool.
Which brings us right back to that invisible marathon. We can run all labs and scans we want, but ultimately, it is about understanding the human body in front of us, physically feeling its changes, and knowing how to support it when it is pushed to the absolute brink. Keep studying, keep questioning, and keep exploring those invisible marathons. Until next time.